My name is Lisa Jacobs, and I'm a surgical oncologist at Johns Hopkins University and Howard County General Hospital. I take care of breast cancer or diseases of the breast and melanoma. The guidelines for screening mammography have been evaluated through a number of government services, and there was a statement made by the U.S. Preventive Services Task Force saying that mammography should be primarily in women over 50 and maybe every other year for a period of time. Those recommendations have been modified over time and they've sort of gone back on that and talked about now doing yearly mammography after the age of 40, which is what we have routinely recommended. We do still at Johns Hopkins recommend routine mammography starting at the age of 40 and continuing on yearly after the age of 40. There's a lot of questions about, is there an upper age limit when you would stop mammography? In general, the upper age limit is when the person's health would not allow them to be treated. So if your health is still good and you would still be able to undergo treatment for breast cancer, we would still want to do mammography. In women who are at increased risk related to a family history or other factors, we would recommend with a family history that you start screening mammography 10 years younger than the youngest age of diagnosis of breast cancer in the family. So if your mother had breast cancer diagnosed at 45, you would start screening mammography at 35. In women younger than 30 who are very high risk, either related to genetic mutations or related to a very strong family history in women diagnosed in their early 30s, we certainly wouldn't start mammography at 25. It's just not that useful of a study. We would start with ultrasound or breast MRI until they reach the age of 30, and then we would go to mammography and MRI starting at 30. So mammography does have false positives, and in fact, when we recommend a biopsy for mammography, 80% of the time it's benign. And that's because we're using features on the mammogram to suggest that there could be a malignancy there that we don't want to miss. There are false positives, and dealing with those, we try to deal with those in the least invasive manner possible, which might mean doing an ultrasound, which might mean doing additional imaging, like compression views, might mean doing a breast MRI. And then if we are still uncertain as to the risk of the lesion, then we might recommend a needle biopsy. We've really tried to move away from doing surgical biopsies where we remove lumps or abnormalities just for diagnostic purposes because so many of the times it's benign and there's no reason to create a scar on the breast. The needle biopsies can be done with minimal discomfort and minimal scarring, which doesn't result in much change at all in the appearance of the breast, and if any change at all in the appearance of the breast. So false positives, the other problem with false positives is the anxiety that it creates. And we do try to spend a lot of time reassuring people that many times it's negative, we're just trying to be sure.